All right, we will start with the lecture now, and welcome to this lecture on benign prostatic hyperplasia today. And I'm going to share the screen with you now. And I hope you can see the screen. As usual, you have to confirm that you can see the screen. Say yes. All right, yes on the chat. I don't hear anyone. Is anyone there? Okay, I got
Yes,
one.
doctor.
All right, thank you very much. So today we'll start with benign prostatic hyperplasia, and this lecture is divided into three parts. In the first part, we will set the stage to go on to the drugs. And in the second part, we will review the drugs. And in the third part, we will look at some surgical procedures that have been developed, okay? So what this title slide shows you is that the normal prostate is the size of a walnut. But when a person gets enlargement of the prostate, it can get as big as a mid-sized orange. And when it gets big, which we refer to as hyperplasia, then it causes certain problems that we will discuss in this lecture. Right, so lecture outline is that we will look at hormonal regulation, relevant anatomy and histology of the prostate gland. We have done this in the previous lecture, which was on prostate cancer, but we will have a quick look at it once again. We'll look at pathophysiology, epidemiology, prognosis as usual, and signs and symptoms, complications, workup. And up to workup, we will be setting the stage, right? And then we will go on to pharmacological therapy and current trends in surgery, all right? So hormonal regulation of the prostate gland starts with the hypothalamus, which is the master gland of the body. And hypothalamus releases certain hormones that act on the pituitary gland. And in turn, pituitary gland will secrete some hormones, which include LH, luteinizing hormone, and follicle stimulating hormone. And it will also secrete ACTH, which stands for adrenocorticotropic hormone, if you remember. So this luteinizing hormone in the testes acts upon the Leydig cells, and the Leydig cells synthesize testosterone. Whereas the adrenals, they synthesize androgens in addition to cortisol and aldosterone. Now, the main hormone that acts on the prostate gland is testosterone. And here is a schematic view of a prostate gland cell. And when I say prostate cell, I mean the cell that makes the prostatic fluid. And as I described to you in the previous lecture, these are the glandular cells. They're also known as the acinar cells. So when testosterone is taken up by this cell, it is converted to dihydrotestosterone under the influence of a hormone which is known as 5-alpha reductase. Dihydrotestosterone has its receptor inside the cell. It will bind to its receptor. It will translocate into the nucleus, and it will cause transcription of messenger RNA. This messenger RNA is going to translate certain proteins that lead to cell growth and proliferation, right? So basically, what I've said in this slide is that it is mainly testosterone that acts on the cells of the prostate gland. Not only the glandular cells, also the smooth muscle cells which are there, and it can lead to cell proliferation. Right. So benign prostatic hyperplasia is also known as benign prostatic hypertrophy or benign prostatic enlargement. And it basically is proliferation of the cellular elements of the prostate, and that leads to an enlarged prostate gland. Now, when the prostate gland enlarges, as I will show you in the next figure, and you have seen that previously in the cancer lecture, when it enlarges, it compresses the urethra and the neck of the bladder. The neck of the bladder is known as bladder outlet. It's known as bladder outlet, and the enlargement of prostate causes bladder outlet obstruction. That may lead to many other symptoms. It is a domino effect. It may lead to retention of urine, impaired kidney function, recurrent urinary tract infections, gross hematuria, and bladder calculi. Calculi means stones, okay? Right, and we'll come back to these complications or symptoms again and again. And the basic problem is that when the prostate enlarges, it may constrict or it may obstruct the flow of urine. Nerves within the prostate and bladder may also play a role in causing the symptoms of benign prostatic hyperplasia. Diagnosis, the most common examination that we do clinically is digital rectal examination, which is an integral part of the evaluation in men with presumed BPH, or those men who come with symptoms that indicate BPH. Ultrasonography is a very useful test, and it can determine bladder and prostate size and the degree of hydronephrosis that could occur in the prostatic hyperplasia. So we can do an abdominal ultrasound, we can do a renal ultrasound, and we can do a transrectal ultrasound that I'll show you later on. So this is the prostate gland, and now I hope you are aware that it's the urethra passes through the prostate, and it is very close to the rectum. And there, that makes the examination of the prostate a little bit easier, all right? So BPH is considered a normal part of aging process in men and is hormonally dependent. It's dependent on testosterone and dihydrotestosterone. And an estimated 50% of men demonstrate histopathologic BPH or benign prostatic hyperplasia by the age of 60 years. And this number increases to 90% by the age of 85 years. And as I will show you later on, by the age of 50 years, about 1/3 of men develop some symptoms, albeit those are mild symptoms, but they do develop symptoms of benign prostatic hyperplasia. And the most common symptoms are known as lower urinary tract symptoms, which are also called LUTs. And they are the result of voiding dysfunction. Voiding dysfunction means emptying the bladder. Voiding means emptying the bladder. That is the result of bladder outlet obstruction. So the two abbreviations that I have used over here, or acronyms, these are LUTs and bladder outlet obstruction. Approximately half of men diagnosed with BPH report moderate to severe LUTs. And clinical manifestations, as I showed you previously, urinary frequency, which means the person has to pass urine at very short intervals, urgency, nocturia, weak urine stream, and feeling of incomplete bladder evacuation. And that could lead to certain complications as well, which could include retention of urine, it could be acute, and impaired bladder emptying, renal and urinary tract infections. Now, coming back to the anatomy of the prostate gland is divided into lobes that I've shown you over here. It has got an anterior lobe, 2 lateral lobes, 1 posterior lobe, and 1 median lobe. And that's a lateral view of the lobes. And you can see that the urethra passes through the prostate gland, and this is the ejaculatory duct, which comes from the seminal vesicles and the vas deferens that brings the sperms from the testes. And here is a cross section, and this shows you the glands in the lobes, and over here in the anterior part, you don't see a lot many glands. Anyway, this once again, a quick review of the lobes of the prostate gland. And this figure shows you hypertrophy, in which the smooth muscle has hypertrophied, or it has undergone hyperplasia. And I hope you remember the difference between hypertrophy and hyperplasia. Hypertrophy is increase in the size of the cell, and hyperplasia is increase in the number of the cells. And there is hyperplasia of this yellowish glandular tissue as well. And this one is important. What I've shown you in this figure is the distribution of alpha-1 adrenergic receptors. Now, what do? They cause contraction of the smooth muscle. And look, they are concentrated at the bladder neck, which is also known as the bladder outlet. And they are spread or interspersed in the prostatic tissue as well. So, when these receptors are stimulated, alpha-1 adrenergic receptors, they will cause contraction of the smooth muscle, and that would aggravate bladder outlet obstruction, all right? And besides these lobes, the prostate is divided into zones as well, and it is composed of different types of tissues. For example, this is the anterior part, and I showed you in the previous figure that it has got very few glands in it. It is mostly fibromuscular tissue, right? So it has got a peripheral zone. We have done this previously as well. It has got a central zone, a transitional zone, and these two, which are not very important from the point of view of benign prostatic hyperplasia or prostate cancer. So the transitional zone that you see is surrounding the urethra. This is the urethra. It grows throughout the life, and this is the zone that is responsible for benign prostatic hyperplasia. And we saw previously that about 10% of prostate cancers begin in this zone. And then peripheral zone is that consists of the bulk of the prostate gland. And when the doctor examines the prostate gland through the rectum, it is the peripheral zone that he's feeling at, and it's mostly glandular tissue in this part. And this is most commonly involved in cancer. Right, and then we have the central zones, and the cancers in this zone are a little bit aggressive, and they can spread to the seminal vesicles. But today we will mostly discuss BPH, which is benign prostatic hyperplasia. So what you see in this figure is that in this one, the transitional zone has enlarged, and you see, if you notice the urethra, this is wide and open over here, but over here the urethra is compressed. And when the urethra is compressed, it will have certain consequences in the bladder. For example, the pressure inside the bladder will increase, and that would cause certain histological and anatomical changes inside the bladder. So the enlargement of the prostate depends on dihydrotestosterone, which is the male hormone inside the prostate cell, and it is basically testosterone which is converted to dihydrotestosterone by the enzyme 5-alpha reductase. Now, it is important to remember the name of this enzyme because we have got certain drugs that are used in BPH that inhibit this enzyme. So dihydrotestosterone binds to androgen receptors. It will translocate to the nucleus of the cell. And, which means that if testosterone levels increase, then there is a higher possibility of getting benign prostatic hyperplasia, and that does happen in certain ethnicities. But we know that serum testosterone levels decrease with age, and this suggests that there are some other factors that play an etiologic role or that contribute to the growth of the prostate gland. And those factors are metabolic syndrome, hyperinsulinemia, norepinephrine, angiotensin II, and insulin-like growth factor. And then we have a large number of alpha-1 receptors that are located in the smooth muscle of the stroma. Smooth muscle that is present in the stroma and the capsule of the prostate gland, as well as in the bladder neck that I showed you over here. So these alpha-1 receptors are very important, and we give certain drugs that block these alpha-1 receptors, and they relieve the symptoms of benign prostatic hyperplasia. Stimulation of these receptors causes an increase in the smooth muscle tone inside the prostate gland, and if the prostate gland is already enlarged and compressing the urethra, contraction of the smooth muscle will further aggravate the symptoms of the lower urinary tract, okay? So castrated males who are unable to make testosterone do not develop BPH. And as the prostate enlarges, the surrounding capsule prevents its outward expansion, and that would lead to compression of the urethra. Now, the capsule of the prostate is composed of smooth muscle as well as fibrous tissue. And what happens inside the bladder is that obstruction-induced changes in the bladder wall include smooth muscle hypertrophy, trabeculations that I'll show you in a later slide, irritability of the bladder wall, and that would increase its own contractile force. Now, if you look in this figure, the prostate is enlarged and the urethra is compressed. And what has happened is, because of the compression of the urethra, the pressure inside the bladder has increased. And you can see some accumulation of urine, which is known as post-void residual urine. I'll come to that point again later in this lecture. But because of the increased pressure inside the bladder, there are certain things that happen, which are the consequences of increased pressure. One of them is detrusor overactivity. Detrusor is the muscle that is in the wall of the bladder. Okay, when this muscle contracts, the person passes urine. And this muscle is under the influence of the parasympathetic nervous system, which means it is stimulated by acetylcholine. So due to increased sensitivity, even small volumes of urine in the bladder increase urinary frequency and lower urinary tract symptoms. So as a consequence, the bladder gradually weakens and loses the ability to empty completely. And that leads to increased residual volume and urinary retention, which you see here, all right? This is urine present. And trabeculations in the bladder, they increase the amount of collagen in the bladder wall. And that will reduce the compliance of the bladder wall. It will sort of make the bladder wall a bit stiff, okay? The presence of collagen limits the contraction and impairs the emptying, and it leads to development of residual urine. Now, what is the function of the prostate gland? We have already seen that. Actually, we saw what the function of prostate-specific antigen was, but prostate secretes an alkaline fluid that comprises about 20% of the volume of semen. About 60% of the volume of semen comes from the seminal vesicles, 60 to 70%, right? So this is an alkaline fluid. It provides nutrition to the sperm, and it also causes liquefaction of the seminal plug, which will facilitate the flow or the movement of the sperms. It neutralizes the acidic vaginal environment, and it also liquefies the mucus in the cervix of the uterus, all right? So prostatic urethra prevents retrograde ejaculation by closing off the bladder neck under normal circumstances. So here is a quick review of what we have done so far. We looked at the hormonal regulation, and we saw that digital rectal examination, ultrasonography are important. Then we saw that the hormones like testosterone and dihydrotestosterone, they cause growth of the prostate. We looked at the anatomy, and we looked at the bladder neck and the alpha receptors over there. We looked at the different zones, and we said that it is the transitional zone that grows throughout the life and causes benign prostatic hyperplasia. And we had a quick look at the pathophysiology as well. And we looked at the detrusor overactivity and trabeculations that develop in the prostate gland that leads to increased amount of collagen and stiffening of the bladder wall. Okay, all of these things lead to lower urinary tract infection, lower urinary tract symptoms, LUTs. Right, epidemiology, BPH is a common problem that affects the quality of life in approximately 1/3 of men by the age of 50 years. And it is histologically evident in up to 90% of men by the age of 85 years. And about 14 million men in United States have symptoms of BPH and 30 million worldwide. I think this is a gross underestimation. There are a lot more people who are above the age of 60 years that suffer from the symptoms of BPH. The prevalence of BPH in white and African American men is similar, but unfortunately in African American men, the progression is faster and the symptoms are more severe because of certain differences, which include higher testosterone levels in African American men and higher 5-alpha reductase activity. There is a higher expression of androgen receptors inside the prostate cells, and there are some growth factors. So although the prevalence is the same, but the severity of the symptoms is more in African American men. Prognosis: in the past, chronic end-stage bladder outlet obstruction often led to renal failure, and it still leads to renal failure if the person does not get proper treatment. Although this complication has become much less common due to availability of management and treatment and drugs, but still, chronic bladder outlet obstruction can lead to a certain symptoms and complications, which includes urinary retention, chronic kidney disease, recurrent UTIs, gross hematuria, and bladder calculi, all right? And there are certain high-risk men. One of them I've shown you previously are men who are older, above 50 or 60 years of age. Then men who have got a family history, whose fathers had BPH, they are high-risk men. Men who are overweight, obese, diabetic, metabolic syndrome, okay, who do less exercises and they don't stay active. And some men with erectile dysfunction are also at a higher risk, okay? Now, patient education is important because this is a part of management, and I've written important over there. So patients should be informed that the following lifestyle changes may help relieve symptoms, and I hope you can guess some of them. They should avoid alcohol and caffeine. They should avoid drinking fluids at bedtime. They should drink smaller amounts throughout the day. They should avoid taking decongestants, and that means nasal decongestants because they have got alpha agonists in them. They cause vasodilation. And antihistamines because antihistamines also have anticholinergic effects. They should get regular exercise, and they should make a habit of going to the bathroom. When they have the urge, they should not hold back their urine. They should practice double voiding, which means that when they have passed urine, they should try to pass urine again a second time. Stress management and relaxation techniques are important. And patients should be warned that if they are unable to urinate, they're at risk for permanent kidney or bladder injury, and they need medical attention in those situations. Right, the symptoms of BPH, this is also important. And remember that it's not only the enlargement of the prostate, it is also the nerves within the prostate and bladder. They may also play a role in causing the following symptoms, okay? Urinary frequency means need to urinate frequently during the day or during the night, which is known as nocturia. Urinary urgency is sudden urgent need to urinate, which is inability to hold back the urine, okay? Hesitancy is difficulty in initiating the stream of urine, which means although the person does have urgency, he wants to pass urine, but he's unable to start the stream immediately as soon as he goes to the bathroom. So it takes him a little while to start because there is obstruction to the urine flow. Incomplete bladder emptying, the feeling of persistent residual urine inside the bladder, that is there, and that has got many reasons. You know, one of them is obstruction, the other is changes in the bladder wall, particularly trabeculations. Straining, is another symptom. Need to strain or push. Valsalva maneuver means contraction of the abdominal muscles to increase the intra-abdominal pressure. That would help initiate the urine flow. Decreased force of stream, which is also known as weak stream. I'll show you a figure and you'll understand what I mean by that. And dribbling is loss of small amounts of urine due to poor urinary stream, or later on when the person goes out of the toilet, the drops of urine leak out, and that might cause him a little bit of embarrassment. So the symptoms that I've shown you over here can be divided into two groups, which are known as obstructive or irritative symptoms. Obstructive symptoms include hesitation before urine flow starts despite urgency, and hesitation is inability to start the urine flow immediately, okay? The person wants to straining when urinating, weak or intermittent urinary stream, a sense that the bladder has not emptied completely. It is known as post-void volume, okay? Post-void urinary volume or post-void residual volume. Dribbling at the end of urination or leakage afterwards. These are the obstructive symptoms. And then we have got irritative symptoms. And irritative symptoms are because of the changes in bladder wall, or they are mainly due to the alpha receptors that are there. Well, not actually alpha receptors, but they are irritative symptoms that are there because of the nerves, okay, not alpha receptors. Alpha receptors will cause obstructive symptoms because they cause contraction of the smooth muscle. So nerves are involved over here, and increased frequency of urination, and urgent need to urinate, and difficulty postponing urination, discomfort when urinating, and frequent nighttime urination, which is known as nocturia, and that is pretty bothersome for the patient because he might lose sleep, or he might not be able to go back to sleep once he gets up for passing urine. So mild disease may stabilize, whereas other patients experience progressive disease, okay, and they have to seek medical help for that. And this is what I mean by a weak urinary stream. Usually when the bladder is healthy and there is no obstruction in the prostate, the urine falls pretty far from the body, but when the urinary stream becomes weak, the stream of urine falls close to the feet, all right? So that is what we mean by weak urinary stream, and we can measure that by urinary flow rate as well, okay? But that is done in the hospitals. Physical examination, the most important is digital rectal examination, but to eliminate some other causes, you can assess suprapubic area for bladder distension. Digital rectal examination is very important, which is done through the rectum, and you palpate the prostate circumferentially, which means you swipe your finger, which is also known as windshield wiper movement, okay? Now, this is an important point. In general, an estimation of the number of index finger pads that one can sweep over the rectal surface of the prostate during digital rectal examination is a useful way of estimating the gland size, okay? For example, one can report that the prostate size was 2 to 3 finger breadths wide, right? Now, normally, each finger breadth is approximately about 15 grams of prostatic tissue, and 2 finger breadths or less is usually normal. It doesn't cause the symptoms, at least. The normal prostate volume in a young man is about 20 grams. There could be, in order to test that or to test the benign prostatic enlargement and its consequences, it is indicated to do a neurological examination, which will show a decreased anal sphincter tone, okay, or lack of bulbocavernosus reflux. Bulbocavernosus reflex is that when you squeeze the glands of the penis, the anal sphincter sorts of tightens up, okay? That is present both in males and females. In females, the test is a little bit different. So pelvic floor tone, you can examine that, presence or absence of fluctuance, which will be present in cases of prostate abscess, all right? And this is digital rectal examination. It is done through the rectum. And as I said, the prostate gland is very close to the anterior wall of the rectum. So you can feel the prostate gland. You can look at the consistency at nodules or at the size of the prostate gland. Now, complications, mentioned them so many times. They are urinary retention, renal insufficiency, recurrent urinary tract infections, gross hematuria, bladder stones, and renal failure. So what I've shown you over here is this is a normal prostate and this is an enlarged prostate that will compress the urethra, and that will have consequences. If you compare this bladder to the normal bladder, you see that the bladder has increased in size. There is some retention of urine, which is known as post-void residual urine. And if you look at the wall inside the bladder, it is quite irregular compared to this one, okay? So impeded flow of urine, urinary retention, and reflux, which is urine going back into the ureter, and hyperirritability of the bladder, which is due to the nerves, hypertrophy, which include the trabeculations and increase in the amount of collagen fibers, development of diverticula. That could happen in diverticula or outpouchings or outpocketing of the bladder. Okay. Then hydroureter, because of the reflux of urine into the ureter and the transmittance of pressure back into the ureter, and that could be transmitted to the kidneys as well. And the kidneys will enlarge. We call that hydronephrosis, okay? And that would, if the person does not get medical attention, that could lead to renal failure. And this is what I mean by trabeculations. You know, the wall of the bladder will become stiff. This is normal. And that would impair the contraction of the detrusor muscle, which is the muscle of the bladder wall. And that would lead to weak stream, and that would lead to retention of urine and infections inside the bladder, because urine is a very good medium for the growth of E. coli bacteria and some other bacteria as well. So this is what we have done so far. We looked at the epidemiology. I said that patient education is important. We looked at the symptoms of BPH, prognosis and complications, and we said that the symptoms are divided into obstructive and irritative symptoms. Obstructive symptoms are due to the enlargement, and irritative symptoms are due to the nerves and stimulation of the receptors in the bladder. Then physical examination, digital rectal examination, complications, and trabeculations in the bladder, okay? Now we go on to differential diagnosis. That's not a big problem because it's not difficult to diagnose. The patient will be above 50 or more commonly above 60, and he will present with symptoms of lower urinary tract, okay? So you might want to exclude prostatitis or prostatic abscess or prostate cancer. That is important, and that could be done with prostate-specific antigen. And obviously, we have seen previously that you have to get a biopsy as well. You can do MRI. Overactive bladder, that could be present with the BPH as well. And we have got a specific treatment for this as well. The person can get cystitis, which is inflammation or infection of the bladder. UTIs and urethral strictures could be there. Now, this is an algorithm for basic management of lower urinary tract symptoms in men. I will not read it. I've written that it's for your self-study, but this is important from the examination point of view, all right? Then laboratory workup. We'll go quickly through this. urinalysis and urine culture to rule out infections. We have many different methods that will be done in the lab. We will send the urine to the lab and we will do culture. We can do prostate-specific antigen. And this is a proxy for volume, but this also is indicative of the risk of prostate cancer. The normal range is 2.5 to 3 nanogram, as we have seen previously. And if a patient wants to do screening, if there is any suspicion of prostate cancer, then he can do it with certain conditions attached to it, but it is entirely up to the person. High-risk people like African Americans, they have to do the screening at a younger age, and very high-risk people who have got certain genes or who have got a family history, they have to do it even earlier, okay? Right. So you have to do electrolytes, BUN and creatinine. These are the renal function tests, but you do not do that in the initial phases. These evaluations are useful screening tools for chronic renal insufficiency in patients who have high post-void residual urine. All right, you can measure that. And you can measure that there are certain ways of measuring post-void urine. Ultrasound is one of them, but there is another better way of measuring that. By better, I mean more accurate. A routine serum creatinine measurement is not indicated in the initial evaluation of men with LUTS, okay? Ultrasonography is important, and you can do abdominal, renal, and transrectal ultrasonography. And what you look for is, you look at the enlargement of the bladder, you look at the residual urine, you look at the prostate size, you look for hydronephrosis, right? And you can look at the enlargement of the ureter as well. Generally, they are not indicated for initial evaluation, just like the renal function tests. Urine volumes measured by ultrasonic bladder scan are quite accurate, but as I said, there is a better way and more accurate way of doing that. Transrectal ultrasonography of the prostate is recommended in selected patients to determine the volume, okay? This is what I mean by transrectal. This is an ultrasound probe which is passed into the rectum, and it's very close to the prostate. It can give you a very good idea of the volume of the prostate. There's a small little cancer over here as well, but this is not good for diagnosing cancers. MRI is better than this one. Okay, and of course, we have seen that prostate-specific antigen is also indicative of cancers when it is very high. Okay, so imaging of upper tract is indicated in certain conditions, which include concomitant hematuria, a history of urolithiasis, which means calculi or stones in the bladder, elevated creatinine levels, high post-void residual urine volume, and history of upper UTI. Upper UTI means pyelonephritis, okay? All right. So CT and MRI do not have a role in evaluation of BPH, although MRI, as we previously saw, is gaining popularity in prostate cancers. Optional tests, without going into details, they are for your reference only. I'll just read the names. Urine flow rate is done in the hospitals, okay? Then post-void residual urine, that is normally done in most of the cases. And a volume of above 350 ml may indicate bladder dysfunction or bladder outlet obstruction. Pressure flow studies could be done, and cytologic examination of the urine can be done, okay? Now, a word about post-voidal residual urine or post-void residual urine, also known as PVR. The term post-void residual urine refers to the amount of urine remaining in the bladder after normal urination, okay? There is a lack of consensus about what constitutes PVR. How much is it? You know, less than 50 ml in adults, normal adults, so we can say young adults, it's pretty normal. In the elderly, which is 66 and above, 50 to 100 ml of post-void residual urine is considered normal, and over 200 ml of PVR indicates inadequate emptying. Okay. The volume of urine can be measured either directly with a catheter, which is considered the gold standard for measuring PVR, or you can do it through ultrasound, which gives you a pretty accurate idea of the volume of urine. All right. Now, flexible cystoscopy can be easily performed in several minutes in an office-based setting. It is important, you know, cystoscopy means visualizing the bladder. So here is a cystoscope. You see, it is a fiber optic apparatus. You have passed the camera through the urethra into the bladder, and you can see the bladder or the changes within on a screen. So it can be done using topically based intraurethral anesthesia that you usually use for passing a catheter in the bladder catheter. Okay. Now, indications for cystoscopy are suspicion of a foreign body or malignancy inside the bladder, history of sexually transmitted diseases, prolonged catheterization, trauma, and findings may reveal urethral stricture as a cause of bladder outlet obstruction. Histological findings could vary. There could be a combination of epithelial and stromal hyperplasia in the prostate, although it is difficult to see that with a cystoscope, but that could be found on a biopsy, which we do not usually do or routinely do in BPH. Now, this is an important point. There could be pure smooth muscle proliferation. Now, if in BPH there is pure smooth muscle proliferation, that means it will respond better to alpha blockers. Okay. More commonly, a fibroadenomyomatous pattern of hyperplasia is there. Now, that would respond better to 5-alpha reductase inhibitors or the drugs that decrease the production of dihydrotestosterone. Okay, in the bladder obstruction leads to smooth muscle hypertrophy, and biopsy specimen of trabeculated bladders demonstrate evidence of scarce smooth muscle and increase in collagen. Okay, we have mentioned this thing previously as well. And this is a cystoscope, and this is a single-use cystoscope. Anyway, this is used for these bladder as well, visualization of the bladder. So this is what we have done. We looked at this algorithm, which is for self-study. We looked at laboratory workup, kidney function test, not done initially, but if there are complications, you can do that. Ultrasonography, we said, is important. There are many optional tests that include urine flow rate, and PVR, post-void residual urine. And there is a lack of consensus in how much urine inside the bladder constitutes PVR or post-void residual urine. Then we have flexible cystoscopy, which is a good test for visualizing the bladder. And this is a cystoscope, right? So this completes the first part of the lecture, and we are going to take a break over here. If you have got any questions so far, you can ask me. Otherwise, we'll take a 15 minutes break and we will come back at 4 p.m. All right. And we are going to have an attendance as well during the next session. So if there is no question, then I'll stop the recording, and please remind me to resume recording when we come back.